Today, our guest speaker is Dr. Rian Casade from Fred Hutch Cancer Center, Seattle, US. He's going to speak to us on CNS disease in adults with acute lymphoblastic leukemia. This webinar is brought to you by Mumbai Hematology Group. It is supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and the team from Zydus, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Rian Casade from Fred Hutch. All our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening and morning or afternoon if you are from the other part of the world. Tomorrow morning at 11:30 a.m. IST, in the French time 8 a.m., we have Dr. Letor speaking to us on differential diagnosis between inherited and acquired bone marrow failure syndromes. Our discussions today include a large number of important personalities from India and surrounding countries. They are put up alphabetically here. I'll keep this slide on for a few seconds. In addition, we have had requests from others as well throughout today, right up to 5 minutes earlier. And we have not been able to put up those names, but they're all welcome to discuss with Professor. Briefly, to introduce our guest speaker, he does not require an introduction. He has been our regular web speaker at multiple occasions, and we are grateful to him for repeatedly obliging us. He's Associate Professor, Division of Hematology and Oncology at University of Washington School of Medicine. He's Associate Professor, Clinical Research Division at the same institution. He completed his undergraduate and medical training at the University of Wisconsin. In 2010, he started Hematology Oncology Fellowship at the University of Washington and Fred Hutch. He then joined the faculty at these institutions in 2014 with a focus on ALL in adults. Since then, he has led several investigator-initiated and industry-sponsored clinical trials of various strategies for this disease, including novel agents and cellular therapies. He has a particular interest in developing novel chemotherapeutic strategies for high-risk populations, including older adults and those with relapsed refractory disease. He has served on the NCCN guidelines panels for ALL and the Leukemia Working Group of the Southwest Oncology Group. Today, we invite him to lecture us on CNS disease in adults with acute lymphoblastic leukemia. With this, I'll stop sharing and request Dr. Rian to take over.
Great, thank you. Please let me know if that does not look okay on your end. So it's a pleasure to speak to you all again. I appreciate the opportunity. Thank you all for joining. As was mentioned, I'm going to be covering a relatively nuanced topic, but one that I think is very important clinically, central nervous system disease in adults with acute lymphoblastic leukemia. I'll cover several different topics related to this. So first, the identification and diagnosis of CNS disease, risk factors, and prevention of this outcome. I'll also talk about the different treatment modalities that can be used, and then touch on some future directions, areas of unanswered questions, and the like. So to start out, CNS disease in ALL is, I would say, is an important problem to at least recognize. There are certain aspects of this that I think make it unique among oncology and hematology. So in adults, it's present at diagnosis in approximately 5 to 10%. So it's not a particularly high rate, but it's high enough that you have to certainly take it seriously. The most important site within the central nervous system is the leptomeninges. So this is typically identified by analyzing cerebrospinal fluid, or CSF. the disease can sometimes infiltrate along cranial nerves. In that respect, it's somewhat similar to basilar meningitis. And in the years that I've been treating adults with ALL, I can only recall one case where a patient presented with parenchymal involvement of the brain or spinal cord. So it is incredibly rare to see that. So a mass lesion in the brain or spinal cord is very unlikely to be related to this. The most common presenting symptoms are actually none. Most patients are asymptomatic, certainly at the time of diagnosis, if that's when it's identified. You can also have non-focal neurologic symptoms like headache or nausea. But as I mentioned above, you can also have cranial nerve palsies as a presenting symptom. That could be facial weakness, it could be diplopia, and so forth. The Children's Oncology Group has a staging system of sorts for describing central nervous system disease. Again, because it's the Children's Oncology Group, this is mostly from children, but it could apply to adults as well. I won't go through each individual line, but it's essentially 3 different levels with subgroups below each. And unlike other, testing where you might just call it positive or negative, this actually tries to assign something of a burden of disease, which they define by the number of white blood cells in the CSF. So it's sort of a graded approach to diagnosing central nervous system disease. One detail I'll point out on this slide, and I'll touch on it on the next slide too, is the distinction of greater than or equal to 10 red blood cells per microliter. That's what they define as a traumatic LP. So why is this important? Well, there's a few different things that could potentially be affected by this. So again, it's defined as a procedure that yields CSF that has more than or equal to 10 red blood cells per microliter. So recall, CSF typically should have 0 or very few red cells in it. So if you've introduced red cells into the CSF during the procedure, there are some potential issues related to that. So the biggest one we worry about really in ALL at least is that first lumbar puncture that's performed is often being done when patients have a lot of circulating leukemia. So that peripheral blood that's going into the CSF potentially has blasts in it as well. So on one hand, that can be a laboratory issue. So you can contaminate the specimen that you send to the lab with some peripheral blood. And depending on how much blood and how much leukemia is in the circulation, that can erroneously appear that the CSF that you've sent to the lab is quote unquote positive. There are some methods to correct for that. There's a so-called Steinhertz and Blyer method that is essentially a ratio of the number of white blood cells to red blood cells in both the peripheral blood and the CSF that you can sort of correct against to see if there's essentially an enrichment of white cells in the CSF specimen relative to the blood. You can use that to sort of deduce or conclude that it's probably real and not a laboratory artifact. But what is arguably a more significant consequence is potentially introducing blasts into the CSF. So this is not a laboratory phenomenon. This is literally either through the needle itself or the damage caused to the thecal sac from the needle that was just inserted, potentially letting leukemia cells get into the spinal fluid. And there's actually some studies from children to suggest that if that first lumbar puncture is traumatic, that can actually be independently associated with outcome. So it is actually a legitimate concern. So how do we address this and the consequences of having a traumatic LP? Obviously, nobody wants to do a traumatic procedure. The word trauma itself, of course, is rather provocative, but the reality is this is not always feasible depending on the circumstances. So thrombocytopenia, something that is often present in these patients when they're having this first LP, can actually increase the risk of a traumatic LP. We typically think of correcting a patient's platelet count to reduce the risk of things like epidural hemorrhage or hematoma or other hemorrhagic complications of the procedure. It turns out when this has been studied, that's incredibly rare and probably not related to platelet count. But what does appear to be a greater risk is this traumatic LP happening. So if the patient's severely thrombocytopenic and you can give them platelets before that first LP, it's probably a good idea. Ideally, you have the most experienced practitioner available perform that first one because of the implications of it. That, of course, is not always feasible. You might consider using fluoroscopy or other modalities to try to make the procedure technically easier. But again, that's not always possible. And one thing that we do at my center, and I think a lot of other places do this too, is waiting for the blast to clear the peripheral blood with the use of systemic therapy before performing that first lumbar puncture. Um, in this circumstance, when we've looked at it, a traumatic LP does not seem to impact outcome, suggesting that maybe that helped reduce this risk observed in children. This usually means giving chemotherapy for a few days to let the peripheral blast count decrease before doing that first procedure. And for practical purposes, that's not really going to have a big impact, I think, in their long-term outcome. A brief word on cross-sectional imaging. I see this not infrequently in patients diagnosed with ALL. In my opinion, I think this is probably only necessary if someone has neurologic symptoms. It's not, I think, a very useful tool for just sort of routine staging purposes like we might do in other cancers. Unfortunately, the technical limitations of CT and MRI do not provide much useful information about leptomeningeal disease unless there's very bulky deposits. And really, the best test to use would be an MRI with IV contrast if you were to pursue this. The CT scan is particularly poor at providing good resolution along the base of skull. But of course, MRIs are expensive and they're uncomfortable. You got a patient who with newly diagnosed ALL, they may be going through all these stressful procedures and stressful information, and then you're going to put them in this cave for a few hours and do this test that's not going to help them much in the long run. So probably not very useful. But if a patient has CNS symptoms, I think it's worthwhile considering an MRI or at least a CT with contrast. Recall some of these patients are going to be thrombocytopenic and coagulopathic and so forth. So sometimes a CNS symptom that you might think is from ALL involvement could actually be an intracranial hemorrhage. That basic tenet of ruling out increased intracranial pressure before performing a lumbar puncture. If somebody has really bad headaches or something, you might want to do a scan just to make sure they don't have midline shift and so forth. And it's possible an MRI could help document infiltration along a cranial nerve that might prove useful later, which again is only going to be in the case in someone with symptoms. So. And now switching gears to risk factors and prevention of CNS relapse. So now these are, patients where they've had their diagnosis, typically started treatment. You're now starting to wonder, okay, well, what's the risk of this particular patient? So the central nervous system falls under the broader category of extramedullary sites. So as the name sort of implies, it's disease that's outside of the bone marrow. But it's important to remember the CNS is not the only extramedullary site. When ALL occurs outside of the blood and marrow, it's classically referred to as lymphoblastic lymphoma. That's probably just an academic distinction, but it's one worth remembering. T lineage disease is typically far more likely to have extramedullary disease than B lineage for reasons I don't think anyone really knows. The figure here on the right is just meant to depict some of the more common sites where ALL can develop. You see the central nervous system, of course, at the top, but you can see it in pleural and pericardial spaces, skin, testis in males, and so forth. But literally any organ or location can potentially be involved. So just as some examples in my own clinical practice, I've seen a couple patients present with painful redness of their eye, and they have a diagnostic study performed at the anterior chamber, and they actually have ALL involving the anterior chamber. I've seen a young woman present with severe vaginal bleeding, and ALL was infiltrating their uterus. And I've also seen a couple patients that presented with a painful ankle seemingly after exercise and walking, and it turned out their ALL had relapsed in the talus of their midfoot. So it can really be in a whole host of different places. The development of extramedullary disease likely relies on a range of complex biological factors that this figure intends to summarize. I will go through every detail here, but when you think about a disease that typically lives in the blood and marrow, suddenly growing outside of that space, there's likely multiple things involved, somewhat akin to metastasis of solid tumors. So you have to think about deriving its own blood supply, the unique biology of the cancer cells themselves that allowed them to escape the blood and marrow and what that might mean therapeutically. You now have this potential for an immunologically active infiltrate that could have different factors. So there's different issues when this disease develops outside of the blood or marrow that, again, could potentially have implications on treatment. Prevention of CNS disease is a hallmark of treating ALL. It's one of the few cancers where active prophylaxis for central nervous system diseases is really a standard for everyone. And we use several different strategies to accomplish that. Intrathecal chemotherapy being the most commonly used and widely recognized one. So most regimens are going to use methotrexate for this purpose, but there are other agents that can be used that are somewhat regimen dependent. The drugs that we use systemically are also potentially able to cross the blood-brain barrier and have effects in the central nervous system. And I list some of the different classes here. I'll just call out asparaginase. The depletion of asparagine that happens with these drugs also does affect the asparagine levels in the CSF. So it's thought the drug itself doesn't cross the blood-brain barrier, but its actions do. And then the different TKIs for pH-positive disease, and I'll cover that a little bit later, but these drugs can also potentially affect the central nervous system. Radiation therapy, of course, is not going to be affected by the blood-brain barrier, but we honestly use it less and less. Hyper-CVAD, probably the most common regimen used to treat ALL, does not include radiation routinely. And those regimens where it is included, it often gets omitted. Patients don't want to do it, or the doctor feels it's not necessary, or both. There are historically some clinical risk factors that can be used to identify patients at high risk of CNS relapse. This is an old study, over 30 years old now, that attempted to interrogate this from over 100 patients treated at MD Anderson. So there were a number of laboratory findings that were associated with a higher risk of CNS relapse, as well as pathologic features of the leukemia. Again, recognizing that this is from the 1980s, some of these terms are not necessarily widely used anymore, like the FAB classification and so forth. But there were only two factors that were independently associated with CNS relapse risk: having a high LDH and having very proliferative disease. So this is using a flow cytometry-based assay to identify what stage of cell cycle the cells are in. And if you have more than 14% of cells that are actively replicating and dividing using this assay, that was also associated with an increased risk. Very few labs do that test anymore. An elevated white blood cell count could potentially serve as a surrogate of that. But no labs, to my knowledge, at least in the United States, are still using that assay. Now, I talked about testing CSF by microscopy, morphology, and so forth. Flow cytometry is another modality that can be applied to CSF. And in several studies, including one from our center, this does appear to increase the lifetime risk of CNS relapse. So if that first LP is positive by flow cytometry, in a retrospective analysis, even though those patients received significantly more chemotherapy intrathecally or intraventricularly through an Ommaya, they still had a higher lifetime risk of CNS relapse. Not quite statistically significant, but certainly clinically relevant, numerically not trivial. And it was the factor most associated with CNS relapse, including LDH and white count and other things. On the other hand, if your initial testing is negative, even though these patients are going to have repeated lumbar punctures over the course of their treatment, many places, including our own for many years, would test those individual samples of CSF to make sure that it was still negative. Well, it turns out that testing is largely worthless because if that first one is negative, we never once identified a positive sample from any follow-up testing. So if you're routinely using, doing testing on CSF as like a surveillance strategy, you can probably stop because it's not likely to help, particularly in someone who's asymptomatic and actively on treatment. Now, in terms of slightly higher quality evidence, there have been some studies specifically in T-cell ALL that have informed my practice, admitting that some of these are extrapolated again from a patient population I don't routinely treat, in other words, children. So the AALL 0434 study by the Children's Oncology Group was a large 2x2 pseudofactorial randomization that looked at two distinct randomized questions. So the first question they looked at was different strategies of interim maintenance. So either a Kapizzi methotrexate and asparaginase-based interim maintenance or a high-dose methotrexate-based interim maintenance. So two distinct chemo approaches to that third block of chemo. The second randomization that was addressed in this trial was the inclusion of 6 5-day courses of nelarabine, the drug that's was originally approved specifically in adults with relapsed refractory T-cell ALL. This trial tried to incorporate this into the frontline approach. The key findings from this trial, so the primary endpoint was for disease-free survival. Nelarabine did modestly but statistically significantly improve disease-free survival. And the Kapizzi methotrexate arm also did better than the high-dose methotrexate arm. Other interesting findings in terms of overall survival, the Kapizzi methotrexate arm had better survival, but the nelarabine arm did not. The best performing arm, so again, these are 4 arms because of the 2x2 design. So the patients that got the Kapizzi methotrexate and nelarabine, they had a 91% disease-free survival rate at 5 years. Now, when you drill down a little bit more into the data, there were some interesting things that sort of emerge. And one of these is that the patients that got the Kapizzi methotrexate-based interim maintenance, they had significantly fewer isolated CNS relapses than the patients that got the high-dose methotrexate arm. And I highlighted from a table the 2 different groups of CNS relapses. So there's isolated CNS relapse on the top, and then there's concurrent CNS and marrow relapses. You can see the latter group, not as many, smaller proportion in the Kapizzi methotrexate group, not statistically significant, but on the whole, fewer CNS relapses. So this might be sort of counterintuitive. We typically think of high-dose methotrexate as having CNS activity. We use it for CNS lymphomas and so forth. Well, perhaps it's the combination, because again, asparaginase can affect the CNS. Maybe it's the combination of the two that is really more effective. And maybe the high-dose methotrexate is really treating more of the parenchyma of the brain and not so much the leptomeninges. And again, that's primarily the site where ALL occurs. So speculation only, we don't know exactly why that's the case. The other randomized question on this trial, again, was the inclusion of nelarabine. And I think maybe the most compelling finding of this trial is shown here, that patients who got nelarabine had dramatically lower rates of CNS relapses. So it's important to recognize the scale on the y-axis here, showing that overall these are rare occurrences. Even in the quote unquote high risk group, it was still 7% or so. But adding nelarabine seems to have a pretty significant impact on your risk of CNS relapse. There was a second subsequent randomized trial in children with T-cell ALL that also tried to address a couple of questions at the same time. One question was whether or not adding bortezomib during induction and delayed intensification was helpful. But they also looked at the utility of prophylactic cranial radiation therapy, or CRT. So for many years, all children with T-cell ALL would receive prophylactic cranial radiotherapy. What this study opted to do was assign patients based on their risk. And interestingly, it wasn't based on their initial CSF testing. It was based on their response to chemotherapy. So patients that were deemed high risk, either by having persistent disease at the end of induction or at the end of consolidation, were assigned to get cranial radiation. If patients had a better response to therapy, that was omitted. The key results of this trial, no significant difference in event-free survival with the addition of bortezomib, so that was not ultimately a helpful addition. It did seem to help the subgroup with T lymphoblastic lymphoma, interestingly. But for this discussion, the most interesting finding, there was no difference in event-free or overall survival compared to the historical results of the prior study I described, the 0434 study, despite only 9% of the patients on this trial getting cranial radiation. So again, in 0434, everybody was recommended to get cranial radiation. On this trial, only 9% did, and despite that, the outcomes were very similar. Sorry, a little bit of technical difficulties there. My PowerPoint froze for a moment. So if you put all these data together, at least as it relates to central nervous system disease, so again, the Kapitzi methotrexate intermittence was superior on 0434. And one of the key things here was the reduced risk of CNS relapses with that approach. Nelarabine did modestly improve 5-year disease-free survival on the 0434 trial, along with significantly reducing CNS relapses. Interestingly, they've subsequently done a subgroup analysis and found that this was largely restricted to children. So adolescents and young adults that got nelarabine on this trial, they did not have any overall benefit. So maybe this CNS relapse thing is the big benefit with nelarabine. And then prophylactic cranial radiation can probably be restricted to those that have a poor response to systemic therapy instead of routinely recommending it for everyone. Now, what about the activity of Abl kinase inhibitors for pH-positive disease in the central nervous system? So there's arguably the best body of evidence for dasatinib. So early studies found that the drug does cross the blood-brain barrier. They've done PK studies on CSF from humans and in animal models, finding it there. These trials also looked at a small case series and found that responses in the CNS were seen on patients given dasatinib. So we know the drug can get there and can work. Perhaps the most compelling clinical data available is from this trial in children with pH-positive ALL, where they randomized them to either imatinib or dasatinib. And an interesting finding from here, not statistically significant, but I would argue clinically relevant, is that patients that got dasatinib had about 1/3 the risk of CNS relapse. I put hazard ratio on the text there. That's not right. It should be the cumulative incidence rate. So dasatinib was also better in terms of event-free and overall survival in this study. So it was a positive trial for dasatinib overall, but it also showed a lower risk of CNS relapse. Now, what about ponatinib? So this has now become, FDA approved in the US and in other jurisdictions. So a lot of us are using ponatinib in the front line where it's available. The data here are not quite as good, but there's some. So it is able to cross the blood-brain barrier. But in the one study that found this, the authors conclude that the drug levels were too low. That, however, was based on a comparison to an in vitro assay, which I would argue is probably not the most clinically relevant way to decide if a drug level is too low. I would say more importantly is, does it work? Does it prevent CNS relapse or treat CNS relapse? And at least in a series of patients that they studied, the rates of CNS relapse were relatively low, despite a number of them having active CNS disease before starting the drug. There are some case reports showing that the drug can be active against patients with leukemic meningitis. So again, a clinical readout suggesting it does work. How often it works or how reliable it is kind of what we don't know. The study that got ponatinib approved in the front line is the so-called Falcon trial, which is cited here. They have not yet reported rates of CNS relapse between the group that got ponatinib and the group that got imatinib, but those data are eagerly awaited. So how do I prevent CNS relapse overall? So when I'm using a hyper-CVAD or related regimen, we take a risk-adapted approach to the number of lumbar punctures that are given. Again, kind of using the risk factors that the MD Anderson group identified some 40 years ago, but bringing it into the modern age, and then using some of their prior experiences with clinical trials and how they've modified them over the years. Basically, if you don't have an elevated LDH or a high white count, the standard number of IT chemotherapy doses we give is 8, but for those that have a high risk feature, we give 10. When that first lumbar puncture is positive by flow cytometry, we will treat more frequently, ideally until the CSF clears, and then resume the standard schedule. If a patient has T-cell ALL and that first LP is positive, we'll sometimes consider adding nelarabine. There are separate phase 2 trials showing that nelarabine could be added to hyper-CVAD, not the randomized trial, of course, that I showed before. But if the CSF fails to clear, that's a difficult situation. There's a few things we'll trial in those cases. We'll consider putting in an Ommaya reservoir. We'll use different intra-CSF chemotherapy agents, refer them to experts like radiation oncology and so forth to try to eliminate it. While we don't have as good of evidence in this case, it's very, very similar to doing MRD testing in blood or marrow. If you're trying to cure somebody and you could still detect the disease, whether it's in your blood or in your CSF, in my view, that's a problem. So if you can't clear their CSF, it likely means they're going to relapse. When using a pediatric inspired regimen like the C10403 regimen, which is the one we use most commonly, I'll usually follow the pre-specified schedule of LPs that the study included, using some of the same strategies to try to clear the CSF if that is unsuccessful. For those with TALL, again, I'll use some of those unique experiences from the COG when possible. I'll prefer the Kapitzi methotrexate approach. I'll consider including nelarabine in patients at high risk. And I'm not routinely offering prophylactic cranial radiation to these patients anymore. I'll certainly consider it again if they have poor response to therapy, or they're planning to get total body irradiation for a transplant, and had some previous risk factors, but it's not a routine part of my practice. All right, so now what about patients with active CNS disease, particularly when they've relapsed, which is going to be the more common scenario? There are a variety of modalities that can be applied here. Some of the same ones we use to prevent it, but of course, this also includes some of the other agents that are available for relapsed or refractory disease. So I'm going to talk about where those potentially fit. But it's important to recognize, at least in adults, there's no prospective data to my knowledge using any of these different approaches. So a lot of this comes either from extrapolating from children or smaller retrospective studies that have described outcomes with these different approaches. And I think there's a number of different factors to consider when selecting from the different options available, such as whether or not this is an isolated CNS relapse or a concurrent medullary and CNS relapse. What is your goal with this treatment? Are you still trying to cure this person who suffered this relapse, or is it more of a palliative approach? Are you trying to get them to transplant? And then just like in general oncology as well, what lines or what therapies have they had before? How did they work? How do they tolerate them? Are there similar approaches that could be used now in relapse? This is one area, even though we rarely use chemotherapy in the modern era, at least in the US, and places that have access to the different immunotherapy agents available, this is one place where I think chemotherapy still has a role. So there have been several, mostly pediatric studies that have looked at regimens in a prospective fashion for CNS disease. The Pediatric Oncology Group, or POG 9412 trial, is one of them. It's one that I use in my practice when this is encountered. It's a very complex regimen. It does include CNS-directed radiation as well as triple IT therapy, really trying to maximize the delivery of treatment into the central nervous system. Here were the survival curves from this study. They did have different risk groups, standard and high risk. By definition, all adults are going to fall into the high risk group, and that's shown on the right panel, the bottom curve, if you can't see that very well. So these patients, don't do particularly well, but can still potentially be treated effectively, and some can experience long-term remission with this kind of approach. So it's something that I'll use again, primarily in patients with isolated CNS relapse, particularly for T-cell ALL, since we don't have any immunotherapy options for those patients. This table summarizes the activity in the central nervous system and the data we have to support it for some of the different agents available. Really, the best evidence we have, and it's not great evidence, but the best evidence we have is with CAR T-cell therapy, and that's mentioned on the bottom two rows there. And I'll talk a little bit more about that in a couple slides. But really, when selecting the different immunotherapy agents available, I will use that knowledge, but then also try to apply it in the setting of the different options available and some of the other factors that I'm considering. Because again, some of these patients will have active systemic disease that we have to consider, or they have social factors or medical comorbidities that might inform the different choices that we would make. So I don't ignore these factors and just give everyone the same thing. If they have active CNS disease, I will think about how I'm going to treat that, while also thinking about how I'm going to treat what other disease they might have and the long-term projections about it and so forth. So a bit about the CNS activity of brexacaptogene autoleucel, the CAR T product that's been around the longest now for adults. This has been looked at in a real-world consortium. There were about 30 patients that were identified as having active CNS disease using the COG method before the cells were collected. So they specifically looked at the outcomes for these patients. Not all of them had a post-treatment response assessment performed, in other words, an LP after the CAR T cells were given, but almost 90% of patients were able to achieve a CNS1 state. So again, no detectable leukemia, at least by morphology. And then when they looked more broadly at outcome and compared them to those that didn't have CNS involvement, the overall outcomes are quite similar, including the rates of severe neurologic toxicity. In the early days, we were concerned, is the presence of leukemia going to recruit more CAR T cells into the CNS and trigger more ICANS? Well, it turns out that probably doesn't really happen. But an important limitation of these data is they were not able to account for any treatment that was given as so-called bridging therapy. In other words, between apheresis and the infusion of the cells. And some of these patients got, cycles of chemotherapy or multiple lumbar punctures. So it could be that the responses we're seeing are actually from the chemo they got before the CAR T cells were administered. So there is an important limitation there, but it certainly suggests that these cells are active. Now, what about cranial spinal radiation for CNS disease? So our center looked at this retrospectively. We found 39 patients that got cranial spinal irradiation for acute leukemia. About half of them had ALL, most were B-ALL. And interestingly, about half of the cohort received proton beam therapy as opposed to photon, the more traditional modality of radiation. Most of these patients went directly to transplant after this treatment, not all, but most. And of the 15 who had detectable CNS disease before radiation started, all that had an assessment afterward had cleared their CSF within about 3 weeks. And there were only 5 CNS relapses observed after delivering this radiation. And interestingly, all of those relapses occurred in patients who also had a systemic relapse, suggesting that the radiation was very effective at clearing the CNS. It was only failure in the systemic compartment that allowed leukemia to enter the CNS again. And the survival curves here again showing, relatively good long-term outcomes considering what we typically think of as a very high-risk situation. I mentioned proton therapy. I think this has some interesting implications for CNS leukemia. I am not a radiation oncologist, so I'm not really equipped to get into all the gory details of this, but I think even a basic understanding of the physics here is kind of interesting. So if you're not familiar with this, proton therapy has this so-called Bragg peak where the particles get accelerated, they penetrate into tissues, and then they sort of stop at a very predictable depth. And then that energy from the particle gets released in a very discrete location. So you could imagine how that could be ideal if you're trying to spare deeper tissues or surrounding normal tissues, and to be able to deliver most of the energy from the radiation to a very discrete area. And that's what that Bragg peak is. So in CNS leukemia, this is interesting because, again, most of these patients, their disease is in the leptomeninges. If you're very precise about it, you could deliver most of the energy from the radiation to the leptomeningeal area, but spare much of the deeper parenchyma of the brain and spinal cord, where we worry a lot about the toxicity. The problem, of course, is a practical one. It's very expensive. There are very few centers that offer proton therapy. So this is not exactly something that you can just pick up and start doing. There's a lot of infrastructure that's required. So as I get towards the end, I thought it might be useful to cover a few cases taken from my clinical experience, just to sort of walk through how I try to implement these data and make some of these decisions. So I'll cover 3 different cases that each had their own sort of unique challenges. So the first case is a 43-year-old man with Philadelphia chromosome negative B-cell ALL. He had a high white count and a high LDH when he presented. Notable pathology results, his leukemia was CD20 positive, but he did not have any detectable cytogenetic abnormalities. And his initial CSF testing showed no detectable disease by traditional methods, but was positive by flow cytometry. He was treated with R-hyper-CBAD. He got 8 cycles, so through cycle 4B. His second lumbar puncture was negative by flow cytometry, so his CSF cleared quite quickly. And his systemic therapy was also quite effective. He was MRD negative by the end of his first cycle. He did have some difficulties with prolonged thrombocytopenia towards the end, which is not atypical, but otherwise his treatment went very smoothly. He got a total of 10 doses of IT chemotherapy throughout his treatment. And because of his lack of any high-risk any high-risk pathologic features in his leukemia and his very good response, we opted not to recommend transplant up front. So then he went on to receive 2 years of maintenance therapy. But unfortunately, about a year after he finished maintenance therapy, he presented to an emergency department complaining of severe fatigue and bone pain. He had a normal white count, but was very neutropenic and had a lot of circulating blasts. His LDH was elevated, and peripheral blood testing unfortunately confirmed that his B-cell ALL had relapsed, still with CD19 and CD22 expression. Because of the relative urgency of his situation, we started second-line therapy with inotuzumab ozogamicin, a drug that can be fairly easy to start, high efficacy, including in patients with high disease burden. He didn't have a lumbar puncture right away because of the circulating blast tissue that I mentioned, but he also would have had a hard time getting into position because he was in so much pain. And because he didn't really have any neurologic symptoms at the time, we felt it was less critical. This may be a bit crass, but sometimes in patients like this, ultimately, if we can't get their systemic disease under control, it kind of doesn't matter what's going on in the central nervous system. So we often aren't at a great rush to do an LP in these patients, again, unless they have neurologic symptoms. So after one cycle, he did have a pretty good response to inotuzumab. He still did have persistent disease, but it was much lower. But unfortunately, that LP that was deferred was ultimately positive. It did have a pleocytosis with mostly B lymphoblast by flow. At this point now, on the heels of inotuzumab, we ended up recommending CAR T cell therapy. When you think about CAR T cells, it takes a while to get them started, but his medullary disease is under control. We know that blinatumomab doesn't have much activity in the CNS, and we can at least continue a few doses of IT chemotherapy while we're waiting for his cells to be collected and manufactured. And these decisions are still ongoing, but our hope is if he gets a response to this, we could then refer him for transplant. And at the time, we'll discuss his case with our radiation oncologist to see if they would include craniospinal radiation as part of his transplant conditioning. So kind of a stay tuned on the outcome there, but that's sort of the way we sort of walk through some of the decisions for somebody with B-cell ALL. The next case is a 25-year-old with T lymphoblastic lymphoma leukemia. He came to medical attention with respiratory symptoms that did not improve despite treatment for pneumonia. His labs were relatively unremarkable. He just had some mild leukopenia, but he had a chest CT that showed a large mediastinal mass. This then prompted a bone marrow test because of that constellation of findings, and indeed, he had about 50% involvement by T lymphoblasts. His initial LP was negative by had a low white count, but was positive by both morphology and flow cytometry. So using the COG methods, he would have been designated as a CNS 2A. We treated him according to the C10403 regimen. Unfortunately, he had a good response to the systemic therapy. Of note, the 0434 study I mentioned was not yet available at the time this patient was treated, so he did not get nelarabine. He was able to complete all of his planned treatment and was able to start maintenance therapy and continue getting IT chemo during that time. Unfortunately, he developed an asymptomatic CNS relapse during his maintenance therapy. And further testing, including bone marrow tests and PET scans, found no systemic disease. So it was an isolated CNS relapse. So because of that, because he's younger and could tolerate intense therapy, and because he had T-cell ALL, we ended up using the POG 9412 study with multi-agent chemotherapy. He had some expected complications, but generally tolerated it well and had a good response in his CNS. He then went on to receive a matched-related donor peripheral blood stem cell transplant with high-dose TBI, along with a craniospinal boost of radiation. He did have a couple lumbar punctures after transplant that fortunately continued to show that his CNS was clear. And now, fortunately, he's over 3 years out from transplant. He's got no GVHD. He's doing quite well and is hopefully cured. The last case is an older patient with some medical comorbidities, not atypical of older age, who now has Philadelphia chromosome positive B-cell ALL, came to attention because of worsening fatigue that led to further workup, including a bone marrow exam that showed Again, BCR-ABL1 positive, B-cell ALL, CNS was negative initially. Because of her comorbidities, we ended up starting dasatinib and prednisone according to the D-ALBA regimen. She had some steroid-induced hyperglycemia, but otherwise tolerated things quite well. She was able to get into a morphologic remission after only 4 weeks, but still had persistent disease by flow. Deeper response after another 8 weeks of dasatinib, but still had a low level of detectable disease by RT-PCR. So with this regimen, that's when patients typically will start blinatumomab. So then, in addition to the dasatinib, she continually started her on blinatumomab. Unfortunately, that was able to clear her low level of residual disease. She got 4 total cycles and got a total of 12 doses of IT chemotherapy, which is what this protocol usually administers. And then she continued single agent dasatinib as maintenance. So overall, went pretty smoothly. Unfortunately, about a year later, she presented to an emergency department because of some new neurological symptoms. They first wanted to rule out stroke because of her medical comorbidities, and this did not show a stroke, but it did show infiltration or enhancement along her left 6 cranial nerve. This led to an LP that unfortunately showed a pleocytosis with a lot of blasts that were CD19 positive by flow. But her bone marrow showed no detectable disease, so an isolated CNS relapse. This, of course, led to a complex set of discussions. This older person with medical comorbidities with an isolated CNS relapse, a really difficult situation. She also lives alone. She wasn't interested in undergoing intense chemotherapy, but she at least wanted to try something. Because of her lack of a caregiver, she wasn't a candidate for CAR T-cell therapy. We ended up starting her on ponatinib, given the expected implications of a CNS, any relapse after dasatinib. And then we gave her weekly IT chemotherapy. We also referred her radiation oncology, who was willing to offer her palliative craniospinal radiation. We did have to hold her ponatinib and IT chemo for a few weeks during that time just to avoid potentially causing more toxicity. And then after the radiation was done, a week or 2 later, after we watched her blood counts, she started low-dose ponatinib, again with the whole hope of trying to maintain her disease. This lasted about 6 months. She had a relatively good quality of life, but unfortunately, she started to develop more neurologic symptoms suspicious of CNS relapse. So this ultimately led to being referred to home hospice, and she was able to die peacefully at home. So not a great outcome, but fortunately, I should say, at least we were able to give her some relatively good quality time and not subject her to a lot of side effects. So the last thing I'll cover are some kind of future directions in the management of this challenging topic. So I think we need better risk stratification based on our CSF testing. There are these data with flow cytometry, but there are certainly other ways that we could try to do this. Ours and other centers have found that flow cytometry can be predictive of CNS relapse and might do a better job of traditional morphologic testing. But at this point, it's really unclear how to change treatment based on these results. It's really just prognostic. It's not exactly predictive. Could we change the IT chemo schedule? Could we incorporate different CNS active agents like nelarabine? Maybe those are the patients we preferentially refer for radiation. We just don't know. As I also mentioned, in our experience, surveillance testing during treatment is not useful. We don't identify like asymptomatic CNS relapses. So don't do this if it's part of your practice, if you're looking to cut down on some costs. But it also underscores that we need a better way of predicting CNS relapse. That's not a very good one. There are some efforts ongoing to try to apply newer technologies to improve detection of CNS disease that might help refine this risk stratification. I'll call your attention to an abstract coming from my group at ASCO in a few weeks that'll touch on this. What about the role of CNS-directed radiation? As I said, this has kind of fallen by the wayside over the years, in part because we're probably treating more people than we really need to. There have been large studies looking at omitting it in children that appear to be safe, one of which I mentioned before. In my experience, even in studies that include radiation as a standard, a lot of patients won't do it. They're concerned about the neurocognitive toxicities, which I totally get, particularly if we can't be certain it's going to help them. As I mentioned, proton therapy has these theoretical advantages, but as you could imagine, you would need a very large and long study with detailed follow-up, not only to identify the risk of CNS relapses, but also neurocognitive deficits and other toxicities. Those are difficult studies to do. So if we'll ever have data in this space, it's probably going to take a long time. And then lastly, kind of touching more broadly on new systemic therapies for ALL, there may be some unintended consequences of these so-called chemotherapy-free approaches, particularly when it comes to extramedullary relapses. So as those that follow this field know, there's been multiple different reduced intensity and truly chemotherapy-free approaches that have been explored. I highlight a few of the higher profile examples here, both for pH positive and pH negative ALL. But interestingly, when you look at the follow-up from these trials, there's possibly a signal of a greater frequency of extramedullary relapses, with the central nervous system being the most dominant site. This is historically a pretty rare occurrence. Only about 10% of relapses in the old days, at least, would involve the extramedullary space. But in some of these trials, about 70% of the relapses are involving the extramedullary region. So again, it might be that we're helping more people overall, but of the people who relapse, relatively more of them are involving the extramedullary domains. And it might be that so-called sanctuary sites, or areas where the cancer cells are relatively protected from either the immunotherapy or whatever, are able to escape the effects of the systemic therapy and then are able to grow back later. And if you're not using chemotherapy, you're allowing that biology to occur. I'm actively working on a review on this topic that might be of interest. So keep your eyes open, particularly at ASH this coming year. So to conclude, CNS is the most important extramedullary site in ALL. There's several factors that contribute to its development, some of which have therapeutic implications. It's important to recognize how this phenomenon or this outcome does have some unique aspects in management, that we routinely prophylax patients against this complication, which again makes it somewhat unique in oncology. Some of the agents we have for relapse refractory ALL do have some activity in the CNS. It's primarily nelarabine and CAR T cells. And really, when you think about it broadly across oncology, how we're trying to get away from using old modalities like chemo and radiation, I think these approaches still have an important role in the central nervous system, again, because of its unique biology. So with that, I'll stop. Thank you again for the opportunity, and I'm happy to take any questions.
Thank you so much, Dr. Rian Cassidy, for that wonderful talk. Complete, a lot of things to learn. Our colleagues are here. They'd like to interact with you and probably ask some questions.
Please.
Use raise hand sign, please. And till that happens, can I ask one question? What's the dose of cranial radiation in the prophylactic setting, in the therapeutic setting, and when you do craniospinal radiation?
Yeah, so it's the doses that are typically used, again, as a non-radiation oncologist, are typically in the range of 12 to 18 gray, as I recall. And some studies, if it's prophylactic, it'll be 12. If it's treatment, it'll be 18. Because you're treating a larger area with the brain and the spine, often those doses are a little on the higher range, just because you're spreading it out over a larger area. So that's usually the range that I've seen.
Thank you. Arihan, your question.
So, good evening to all. Thank you, Dr. Rayan, for your insightful talk. So, I had a couple of questions. First of all, like we conventionally know that a testicular involvement at baseline portends a higher CNS risk. So, and we do a clinical examination at baseline to check for testis. So does that also hold true for ovarian involvement in women or female AYA patients? And do you think bulky ovaries or screening from them, say by an ultrasound or something, is important? And would that pose them at a higher subsequent CNS relapse risk? So that's my first question.
Sure. Yeah. So, to my knowledge, what you're describing there, all correct, all true, but largely have been described in diffuse large B-cell lymphoma. So testis involvement, other genital urinary sites are associated with a higher risk of CNS relapse in diffuse large B-cell lymphoma. I'm not aware specifically in ALL where those are a greater risk of CNS, at least not in the literature I've reviewed. With the testis, of course, you've got a blood-testis barrier that's analogous to the blood-brain barrier, and it's not too hard to imagine why, if the leukemia is able to cross that barrier, it could cross the blood-brain barrier as well. So it's a little bit easier to logically deduce. It's harder for the ovaries, but that it's still the case. It's still true. What you said is correct. Again, in DLBCL. I would not necessarily treat somebody with ALL that had genital, i.e. testis or ovary involvement differently in the central nervous system based on that alone, in part because, again, these patients are all routinely going to get CNS-directed prophylaxis with lots of lumbar punctures and IT chemo. That's not the case with DLBCL, where it's a lot more controversial. But certainly for males that have testicular involvement, there's important things to look for there. You have to make sure whatever the lesion was goes away. They might need testicular radiation if they don't respond. So there's important distinctions there, but I wouldn't necessarily change the CNS-directed therapy on that basis alone.
Thank you. The other question is you talked about that the PEG-ASPAR with Capezi methotrexate was kind of doing better in comparison to the high-dose methotrexate. So, do you think that it's important to incorporate PEG-asparaginase kind of close to or proximal to the methotrexate, or if we are giving it, say, earlier, say week 4, week 5, and post consolidation, will that do equally well, or that combining them together is important for a synergistic activity?
I suspect it's probably the latter, that there's some synergy involved by giving the two drugs in close proximity, at least the way the COG studies are designed. I mean, they're getting the PEG-asparagase during the earlier phases too, but then with the Capezi methotrexate, the 2 doses of PEG-asparagase that are given in the COG approach are given the day after they get a dose of methotrexate. So it's in fairly close proximity. So I imagine there's probably some importance in the close proximity of administration.
And so 2 more questions, sir, if I'm allowed.
Please go ahead.
So one is, is there a dasatinib dose? So a lot of times we do end up cutting down the dasatinib dose during their intensive chemotherapy arms. So is there a dasatinib dose below which the CNS activity or the CNS penetration is kind of impaired, or we don't have data for that?
The short answer is I don't know. I mean, I would imagine that if you use lower doses, there's just going to be less drug in the system to be able to enter the central nervous system. I'm actually pulling up the study that did the PK analysis that actually measured drug levels to see if I can get a quick answer to this question. I won't belabor it too much, but it looks like it does look like there's a bit of a dose response. In other words, giving higher doses is probably more effective at getting into the CNS. But is there a threshold above which, it must be that I don't know. In my practice, I'm typically using 100 milligrams a day at least. I'll sometimes drop down to 70 if they're having, pleural effusions and so forth. I pretty rarely use less than 50.
2 more questions. So prophylactic cranio CRRT. So
Yep.
at least in our setting, it does kind of come with a so it has its own advantages, because preferably it's probably cheaper than the admissions and whatnot. So, what exactly are the long-term risks we are kind of anticipating when we are giving that 12 gray prophylactic CRRT dose, and so that we are in a better position to counsel our patients and choose ourselves between one and the other. So
Yeah, it's unfortunate. I don't know enough to give you real precise in terms of the exact neuropsychological, effects, but the things that our radiation oncologists typically will tell patients is, slower cognitive processing, maybe some mood changes. Again, that could just be a secondary effect of just the processing not being as sharp. The challenge, of course, is, as you said, you need long-term follow-up to really know this. And not even with the advance of things like proton therapy, but just with better conformal techniques of photon therapy, whether or not the way that our radiation oncologists are currently delivering cranial radiation therapy is truly reflective from a toxicity standpoint as what was used back in the 70s and 80s, where, children's trials were done. And then the other thing, of course, if you're, the effects on kids are probably very different than the effects on adults. There's still ongoing development for kids. There's endocrinologic issues and secondary cancers and things like this. But if you're treating a 70-year-old that already maybe has some mild cognitive impairment, are they spared that, or is it actually worse? These are issues we just don't know. And I think it's a lot of that unknown that makes people uneasy about doing it, because we can't very accurately counsel patients on what to expect. And they're like, well, if you don't know if it's going to help me, but it could cause these really bad side effects that kind of make me who I am, a lot of people just don't want to do it, particularly adults.
and so isolated CNS relapse, once you have brought brought them into remission, whether by recurrent intrathecals or plus or minus radiation. So would you kind of counsel them, or would you take them all to a transplant route, but if they are eligible for that, or would there be a subset where a transplant may be kind of avoided?
Yeah, honestly, we probably recommend transplant for most of these patients, but what the transplant is exactly providing, I don't know, because I don't know if we really know if the graft versus leukemia effect is something that truly crosses the blood-brain barrier. What a transplant may be serving is really kind of like an auto transplant for lymphoma or myeloma. It's really the high dose therapy that's getting into the central nervous system that's having the effect. And because of the consequences of that and the potential long-term cytopenias and so forth, giving them the stem cells is more of a stem cell rescue as opposed to the actual transplant. That's only my hypothesis. I don't really have any data to truly back that up. So because these patients are going to be at very high risk of relapse, a CNS relapse is often associated with a systemic relapse, even if you can't detect it. There's usually a pretty compelling argument to be made to go ahead and do the transplant if they're otherwise eligible. But I'll admit, is it critical that the alloreactivity against the leukemia is part of that? We just don't know.
And so we do encounter, though rare, but we do encounter these patients of ALL who would come up with particularly a facial palsy, a Bell's palsy or a seventh nerve palsy, and the imaging would be clean. A lot of times, a good CSF would be clean as well. Maybe a little bit of high proteins in the CSF, and that's all. But we are not able to see the malignant cells either by a flow or by a morphology. In those cases, do you kind of brand them as a CNS relapse, or how do you approach that situation?
I usually consider that as tantamount to CNS involvement, similar to detecting lymphoblasts in the CSF. What might be happening there is that the cells have kind of infiltrated along the cranial nerve, and it might technically be extraaxial or extracranial where that's happening, but kind of like retinal involvement or ocular involvement in DLBCL, how we think of that as like a CNS equivalent sort of site where it's so easy for the cells to just migrate along. It's probably analogous to that. So I would generally view that as an equivalent to CNS involvement.
One last question. So intrathecal rituximab is safe. That kind of we know from.
Yeah.
So do you think so do you think adding on to our routine triple IT in the therapeutic setting, not in the prophylactic setting, but when we are using it to clear the disease,
Yeah.
do you think it would work, or?
It's probably worth a try. I mean, I'm not sure I've ever done it. That's not because it's not a good idea. It's not a very common scenario, but I think if you've got somebody that the blasts are CD20 positive, and particularly if they've relapsed, like you said, it would be worth a try if you're having a hard time clearing their CNS.
Thank you.
You're welcome.
It is worth having Arihant here. Very thought-provoking questions, unusual questions, and good, interesting discussion. Thank you. Prakash, you go ahead.
Good evening, Dr. Cassidy. I think an excellent presentation. My quick question is whether intrathecal thiotaper has been, there's enough experience to say it in fact has response rates in CNS disease, particularly therapeutic.
Yes, I've used it a few times. When I'm reaching for intrathecal thiotepa, it's usually in conjunction with like a neuro-oncologist or something that's helping kind of make those decisions. But I would say because there's not as much experience as methotrexate, cytarabine, triple therapy, it's usually like a third or fourth line choice for me. But you're absolutely right; it can work. And it has a unique mechanism of action against the leukemia that those other drugs don't have. So it's certainly a worthy consideration, but I don't use it as often as the other options.
Thank you. Thank you so much.
You're welcome.
Thank you, Prakash. Rita, your question.
Good evening. Good evening, sir. We all fear CNS involvement in ALL, actually. My question is about flow cytometry. I saw in your presentation that you have used flow cytometry in every CSF sample. Do you think it is helpful or gives some extra advantage in CNS3 disease also when the blast is obvious on the cytospin?
In that case, probably not. I mean, you might be able to speculate a little bit, particularly in the relapse setting. And you have available things like CAR T cells and so forth, since you don't get the immunophenotype with the cytomorphology, at least with flow, you can see, yep, CD19 is there and know that the target is present. Admittedly, including the study that we did at our center, we used flow cytometry strictly as a categorical positive, negative kind of thing. What we don't know is, can you look at more of the details like the proportion of cells that are positive, antigen expression, things of that nature to possibly refine it a bit. But if it's bad enough that you can see it with morphology, the flow, I think, probably just confirms it. I don't know if it adds necessarily anything to the treatment approach, except, again, to verify that an antigen that you're targeting is present.
Suppose it is CNS2 disease and you have done flow and it is positive. So you repeat it every next CSF that you do, you repeat flow cytometry. So you do it till the time that you get negative, or you do it later also?
Typically, in that case, we'll test it until it's negative, and we usually like to at least get a couple negatives in a row to make sure. And then if the patient is staying on treatment and isn't having any major delays and is asymptomatic, we usually stop testing at that point, and only would test again if they had some new symptoms. There are some exceptions to that. We'll periodically test during maintenance therapy for patients that got a pediatric inspired approach, since the LPs continue and they're not happening so frequently. We'll test usually every 3 months. During that stage, you will sometimes catch some CNS relapses in that circumstance. The data that I showed where it's not helpful was with hyper CVAD, where all of the LPs are happening like in the first couple of months. And there, I mean, you could, since those, generally speaking, if you don't have CNS involvement up front and you're on therapy, if you're going to have a CNS relapse, it's probably going to happen years later, kind of like the case I described. So the likelihood of catching it like during month 2 of treatment also just, it doesn't kind of make a lot of sense. So that's where it's probably the least useful and could be omitted, is in that initial first few months of therapy. If you're doing LPs later, again, because that's part of the regimen, surveillance might be useful, but just like surveilling the blood or the marrow, catching it early we think is helpful, but we don't really know. They're probably going to come to medical attention at some point anyway. Are you just adding to cost and anxiety and stuff? We just don't know. But we do it in the maintenance phase sometimes.
And do you have research on any other technique like RT-PCR or NGS on CSF?
Yes, but I am not at liberty to discuss it because it's under embargo. So yeah, at ASCO, we'll be presenting some very preliminary data from a study that we're looking at this specifically with NGS with some interesting findings. So stay tuned.
Thank you.
You're welcome.
Thank you so much.
Thank you, Dr. Rita. Dr. Sohini?
Good evening, sir. I have 2 questions. The first one is, we have been discussing intrathecal thiotepa for the management of CNS diseases, but is there any role for systemic thiotepa? Because there's a lot of discussion of thiotepa on matrix and all of the CNS lymphoma protocols, and they seem to do very well. So why is there not much data or much studies which focus on systemic thiotepa for patients who have developed CNS relapses in leukemias?
Yeah, we don't. I've never used systemic thiotepa in the treatment of ALL, right or wrong. Where we do use it, in fact, in a patient that I'm actively treating right now, since it is included in several different conditioning regimens for allogeneic transplantation, including cord blood transplant and so forth, we do use it there in cases that have CNS involvement. I think the challenge is particularly in B-cell ALL, where it's a pretty rare complication, and we've got, at least in the places where they're available, newer immunotherapy agents that are much more active in the systemic disease. Much of the attention and resources have been devoted to optimizing those. But your point is very valid, including T-cell ALL, or in cases that are refractory to the immunotherapy agents, could thiotepa possibly be involved? I'm sure one could apply a regimen like Matrix or some other regimen to at least try it in a case where there was CNS disease that wasn't responding.
My second question is about the third case that you presented, the patient who eventually went for a hospice-based care.
Yeah.
You showed us that at relapse, the bone marrow was not involved and the RT-PCR was negative for PCR-ABL. So in this particular scenario, would it be the same clone of disease that's come back, or is it a totally different clone that would have come back? Because we often face this scenario and we are not very sure how to go about it.
I mean, while you could argue, it's probably a unique clone that managed to get into the central nervous system. I suspect it's probably fundamentally all from the same disease. I know it can happen, but I personally have never seen a case of Ph positive ALL lose the Philadelphia chromosome at relapse. Again, it can happen, it's been reported, but it's like a case report level of frequency. So to be true, we don't routinely do testing for Philadelphia chromosome on CSF. It's possible. Our lab doesn't do it routinely. We sort of assume that it's there. But that could be a bad assumption. The fact that the PCR was negative and the flow was negative and everything else was negative on the bone marrow, it's probably not that there was like a subclone that was pH negative that relapsed in the systemic compartment too, because we would have seen it with the other testing we did. But your point is valid. It's possible that that was the mechanism of relapse. It just so happened to affect the central nervous system.
Thank you, sir.
Thank you. Arihant?
So, two questions, kind of heading towards the transplant scenario, if I am allowed to ask. So one thing is, whenever we are talking about this CNS boost, and if in a myeloablative setting, say if we are typically using a 12 gray TBI, would the CNS boost be above this 12 gray, or it's kind of included in that? So that's my first question.
Yeah, so it's above that. So there's when we give 12 gray TBI, the amount that actually goes into the brain and spinal cord, I'm not a radiation oncologist, but I think what I've seen in the reports is it's more like 2 or 3 gray or something like that. The boost is done to bring the total dose that's going to that anatomic location to more like 12 gray. So, but then of course they have to account for, particularly when photons are being used, even though they're targeting at the central nervous system, there is going to be some delivery to the liver or the lungs or other organs and the marrow and stuff. So they do have to account for all of those things as well. But for the central nervous system, it's additional radiation on top of what the TBI is delivering.
And if for some reason you are not able to do a TBI-based conditioning for your ALL patients, and you still want to have a reasonable CNS activity, so what would be your preferred non-radiation conditioning regimen, or is there a... And the other question... Yeah, please.
No, to the question that was raised before, in those cases, we usually try to incorporate thiotepa, since it does have known CNS activity when given systemically. Admittedly, I am not a transplanter in the traditional sense, so I'm not usually the one that's making those decisions about the specific conditioning regimen. So I'm not as well versed in all the different nuances. But when I get involved in these discussions, that's usually what we're sort of advocating for, whether it's in combination with fludarabine and busulfan and so forth. That part I'm just not as familiar with. But I would say try to include thiotepa to the extent that probably is helpful.
And do you continue to do so the post-transplant period? Do you continue to kind of surveillance for CNS relapses, and would you recommend, particularly if it was a high risk case to begin with, and post-transplant intrathecals as well, or you think it's not required? Because we know that the CNS GVL is kind of conjectural or doubtful.
Yeah. Personally, I don't think it's very helpful. It was done, in the case that I described, the patient had a couple lumbar punctures post-transplant. In the very early stages, maybe it would be useful to be able to counsel patients because of what the implications of that would be if they're 2 months later and they've already had a CNS relapse. That's likely a very poor prognostic situation where you may start to counsel folks on the probability that they're going to die from their leukemia. But once you get beyond that, honestly, it's kind of like I was saying before. If you've got a patient that's had a first CNS relapse and now has gone through a myeloablative transplant with cranial spinal boost, you're probably not going to have a ton of options available if they do have another CNS relapse. And if they do, it's not clear that treating it early is going to be any better than treating it later. And because lumbar punctures are a lot more unpleasant and challenging than like just doing blood tests, I'd probably not subject the patient to it and just cross your fingers that their disease will stay away, but have a low threshold if they show up with new headaches or nausea or whatever.
Thank you.
Thank you, Dr. Sohini.
Sir, well, it's a rare complication, but it is not uncommon to find patients who develop methotrexate-induced leukoencephalopathy.
Yeah.
So when we come across these patients where they have not completed their 10 ITs or 12 ITs, but they've already gone into methotrexate-induced leukoencephalopathy, what do you normally do, sir?
Yeah, in those cases, usually after a fair amount of counseling, what we will usually do is switch their IT chemo to cytarabine, and see how they tolerate that. And as long as they don't have worsening symptoms, whether it's headaches or confusion or seizures or whatever, we just try to avoid the methotrexate altogether, since it seems to be a unique complication of that drug and not intra-CSF chemo per se that's causing it. I would say our anecdotal experience using that approach has been pretty good. We haven't seen a lot of worsening side effects, and of the few cases where we've encountered it, it's not like all of them relapse later. So that's usually, for at least for the regimens that are only methotrexate based, just switching to cytarabine is probably a safe alternative when that happens.
So the patients who are on triple intrathecal therapies that we often give, we just back off on the methotrexate and just give the hydrocod and the cytarabine, sir?
Yes, that I would do the same thing there. And I know obviously some of these are regimen dependent. For what it's worth, I think it was the Children's Oncology Group at one point did a randomized trial looking at triple IT versus single agent methotrexate. In that context, the triple IT therapy didn't help and it was just more toxic. So I don't use a lot of triple IT therapy. Again, it's probably regimen specific, but at least you can use those data and say, okay, well, if they had a side effect from the triple IT therapy, it's probably safe to back down to just single agent to try to make it safer so you're not completely omitting it.
Sure, sir. Thank you.
Yep.
Dr. Shilpi.
Good evening, sir. Thank you for the excellent talk. In addition to the question asked by Dr. Ritu Saxena, I would like to comment. We have had a few cases where flow cytometry detected blast population that were missed on morphology or it was equivocal. So in such cases where the conventional cytology or morphology of CSF appears negative or equivocal, how do you see role of flow cytometry in refining CNS disease assessment in ALL? Especially the problem comes in the cases where WBC is less than 5.
Yeah. I mean, so at least from our experience, those positive cases by flow cytometry but are negative by the cytocentrifuge or morphology or however you want to call it, they are still important. They still do portend a higher risk of CNS relapse. So just like with bone marrow examinations. So, for many years, it was all about morphology and we didn't really know what to make about flow cytometry. Now, at least in ALL, we know that if you still have detectable disease by flow, the disease is still there. It still has prognostic significance. If you're going to cure the patient, you got to eliminate it by that measure too. It's the same idea in terms of level of sensitivity and detection. Where it gets more complicated from a technical standpoint is because CSF has so few cells normally, there need to be a sufficient number of events in the specimen for it to technically be evaluable. So sometimes we'll have patients that have, very paucicellular, less than 5 white cells per microliter. They run it through the flow cytometry, and then we'll get a report back that is also equivocal, like the morphology review, except it's not equivocal that they can't tell what the cells are. They have the right immunophenotype for B lymphoblast, but there's only like 3 events or 6 events in the entire tube, right? Those are also probably important, but because of the technical limitations of the assay, we just don't know what to make of it. So in a case like that, I wouldn't necessarily change their treatment a priori. Like I wouldn't suddenly refer them for a transplant or recommend they get radiation or whatever. But I might consider maybe doing a couple extra LPs up front to really make sure it clears. If they had T-cell ALL, maybe I'll include nelarabine with their treatment, where I wouldn't otherwise. So it's probably important when you encounter this thing, but again, we're limited on the knowledge of what to do to account for that. So if there's reasonable changes that you can make to the treatment that aren't too drastic, it's probably worth a try to avoid exposing them to too much toxicity.
Thank you, sir.
Thank you. Amit?
Yeah, sir. I have a question. Sir, if the patient has got marrow, which is completely in CR, morphological CR, but MRD positive, and now coming with a CNS relapse, is this to be considered as isolated CNS relapse or should be considered as combined one? And how to approach with this case? Because completely morphological CR, but only MRD positive by flow cytometry.
Yeah, I would consider that a concurrent medullary and CNS relapse. I mean, I think while, older studies wouldn't consider them as such, and unfortunately, current studies might not allow them to enroll because they don't have enough disease in their marrow. Fundamentally, the issue is you've got disease in both compartments. It isn't only in the CNS. So I think I would ensure that what treatment I was using was also adequately addressing both areas. So those would be patients where I wouldn't just use, I certainly wouldn't use IT chemo alone unless it was an older patient who just wasn't going to tolerate anything. I would try to use some of the immunotherapy agents available to try to more effectively treat the medullary or systemic disease, ideally with something that would also cross the blood-brain barrier. So whether that is CAR T-cell therapy, where you're hopefully addressing both, whether that's, you can't do CAR T-cells, but you can use blinatumomab, can we, give a couple doses of IT chemo and then give the blinatumomab and see how that goes. You generally don't want to give IT chemo and blinatumomab at the same time. That does increase the risk of neurologic side effects. So I would try to avoid that if you can. But so I would definitely, and again, and determining success with treatment, I would also make sure, their marrow is also clearing just like their CNS is. And then if they're a candidate and so forth, recommend they get a transplant. In kids that truly have an isolated CNS relapse, as you may know, with some of the chemotherapy-based approaches, if it's a late enough CNS relapse, they won't transplant those children because they can cure a subset of those with chemotherapy alone. Fairly reliably. I mean, if you remember the curves that I showed, some of those standard risk patients, the survival was like 70 or 80% or something for CNS relapse. So they won't routinely recommend transplant in those circumstances. For adults, I would say we typically would. And again, it's as much to treat that medullary disease as it is their CNS.
Thank you so much, sir.
Okay, that complete the questions from the faculty here. There are some questions in the chat box. Sir, do you have time to answer them?
Yeah, I have a few more minutes. Sure.
There are some questions related to what decides that a drug can be given intrathecally or not. For example, blina and L-asparaginase cannot be given intrathecally. Why?
Yeah, I would imagine these are things that are done very early on in drug development, probably starting with preclinical models, whether they're non-human primates or even in vitro biochemical type testing that show that they're just not safe and cause prohibitive toxicity. I imagine that's how it's done.
Thank you. About triple intrathecal, there are questions. Is there a particular sequencing of the drug? Do we have to keep a certain gap between the three drugs? What is the dilution of the drugs, etc.?
Yeah, admittedly, some of this is a bit outside of my range. There are unfortunately several different studied drug dose combinations that are out there, and I'm certainly not aware of one being better than another. I think the combination that our center uses most frequently, and I only remember this because the numbering sequence is kind of easy to remember, it's something like 6 milligrams of methotrexate, 12 milligrams of hydrocortisone, and 24 milligrams of cytarabine or something like that. So it's like 6, 12, 24, and it's kind of easy to remember that way. These, admittedly, in terms of how they're diluted and so forth, that would probably be best answered by a clinical pharmacist. It's not my training, unfortunately. But that is not to be viewed as the best. I would certainly not, if 12 milligrams is viewed as a standard dose of methotrexate and 100 milligrams is viewed as a standard dose of cytarabine, I would not put those two doses together. That would probably be too toxic. I think you do have to reduce the doses of both of them to avoid some of that toxicity.
Thank you. There's one question to you and Dr. Prakash about the dose of intrathecal thiotaper.
Ooh, Dr. Prakash, do you happen to know it? I'd have to look it up, which I can do, but I don't know it off the top of my head.
The other question is your management of paraplegia on hypersevere therapy.
Yeah, I've seen it a couple times. It is awful. The presumptive explanation is it's some sort of local neurologic toxicity to the spinal cord from the IT chemotherapy. Again, mercifully, it's rare. I mean, usually we stop all the IT chemotherapy depending on what the patient's goals are. If you can still continue the systemic therapy, I certainly try to do that while working with, physical medicine and rehab to try to help the patient account for their new deficits. The cases that I've seen, it's permanent. It doesn't get better. It's terrible, 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 terrible. I still remember the patients where that's happened years later. All you can do is hope it doesn't happen. Fortunately, it's very rare. But yeah, I would stop the IT chemo for sure, and then hope that the systemic therapy ends up being sufficiently active to eradicate the disease.
One question about nelarabine-induced GBS, Guillain-Barré syndrome. Have you seen that? How common is it?
I've not seen GBS specifically. I've seen a couple cases of like a transverse myelitis, where again, it's like a paraplegia. Those cases were reversible, as I recall, but they were pretty profound and pretty problematic. The thing that I've done with nelarabine in my practice that I think might reduce this chance is when the drug was originally studied in adults, they gave a dose of like 1,300 milligrams on days 1, 3, and 5. That was the US study that got it approved by the FDA. Some of the newer strategies where they're combining it with other agents and so forth, or they're incorporating it with multi-agent chemotherapy, the dose is less. It's like half that. And there doesn't appear to be the same degree of central nervous system toxicity with the drug. So I almost never use the labeled dose for nelarabine as it was originally studied. The lower dose does, and again, that's where a lot of the CNS activity data come from, is that lower dose. So it's seemingly still effective, but hopefully less toxic.
Another question is, when you're giving intrathecal methotrexate, can we give just cranial radiation and no spinal radiation at all?
Yeah, I've always struggled with this. It doesn't really make a whole lot of sense. The two compartments are connected. Why would you not treat the whole thing? I don't recall a single case where we've just done cranial radiation. I think the assumption is these cells are like circulating throughout the entire neuraxis. So presumptively, the cells that were in your spinal fluid on day 1 of radiation will work their way back up to the head by day 6 and get radiated there, I guess is the idea. And you're sparing the toxicity by just radiating the head. But again, I almost never use that approach in this situation. Most of the patients I refer for radiation are getting cranial and spinal, again, often as a package deal with transplant.
Another question is, what are your indications for prophylactic cranial radiation?
Yeah, for me, I would say it's probably the only cases where I would recommend it would be somebody with T-cell ALL that that did not respond very well to systemic therapy. And frankly, even though the Children's Oncology Group trial didn't use it in this setting, I think the radiation oncologist would be loath to treat somebody that didn't have documented CNS involvement at presentation. So if they had documented CNS involvement at presentation and maybe didn't respond super well to systemic therapy, those are patients I'm usually recommending to get prophylactic cranial radiation. The other circumstance that I would consider it is if it was like, this isn't really prophylaxis anymore, but if it were a patient that had true CNS disease that we then got back into remission and then got a transplant, those are patients we do often recommend get a craniospinal boost as part of their conditioning.
Last questions are from Dr. Roshni. Is Kapezi methotrexate only for DALL and high-dose MTX for the BALL?
So technically, the COG studies, they found that the high-dose methotrexate was better than Kapezi methotrexate. Technically, if you look at the very fine details of those studies, the benefit was not really observed in the young adults. And the studies that have largely been done, at least the C10403 study that used those regimens in adults, used Kapezi methotrexate. So I typically don't use the high-dose methotrexate based approaches for the patients I treat with B-cell ALL. The exceptions to that are if patients had a reaction to asparaginase, whether it was allergic reaction or pancreatitis or whatever, where I can't give asparaginase anymore, the high-dose methotrexate-based intermittence doesn't include asparaginase. So you at least, you don't have to omit the drug because it's not normally there and you're giving a regimen that you know is effective and so forth. If it's a patient that didn't have a very good response to induction therapy, but they can't get a transplant or whatever reason, we've also sometimes used the high-dose methotrexate in those situations, but it's pretty rare.
That was the last question. So thank you.
Okay.
It took a lot of your time and was a fun Q&A session we had. Thank you for being with us. And good night to everybody from India. And have a wonderful day ahead, Dr. Rian.
Thank you all.
Bye.
Thank you,
Bye-bye.
sir. Thank you, sir.
Thank you. Thank you, everybody.